Our next presenter is the Dr. Ajoy Paul. Any introduction is less for him, so I'll let him proceed with no introduction, but he is one of the gurus of ophthalmology for Kolkata and Bengal. There are many people who have grown under him. Let's hear from him.
Thank you, Swati, for that. Am I visible and audible? Hello?
Yes, you are visible.
Okay, thank you. So I'll be just, as you have asked me, the toric, toric I will push your limits, the difficult and challenging. These are surgical difficulties. I'm not saying on the marking or etc. Arup has already shown you. So what about these different cases? Now, this is a toric in small pupil. Now, most of the time, small pupil, I would not like to put any dilating device because the post-operative, when if you leave it a bit dilated, more than 3 millimeter, a lot of glare and all, you lose your toricity and then patient starts complaining a lot. So this is one of the case where it was almost 3.54 millimeter. I did the Rexis just going behind the iris and just put in, this is one of the T3 lenses of Alcon Acris of IQ and see, and then just to see the position, you just have to move with your force with one of those instruments. And this is a small people had to put a hook because this is earlier days, this is almost 10 or 12 years back. See, I'm putting a doing dilatation with my viscodilatation after stretching. This is around 4 millimeter Rexis, and here I come and I see I'm losing the Rexis, and I had no other way of putting the iris hooks there. I have just inflated it too much to the periphery there and going and doing the completing the Rexis here, and I've got my mark or preoperative marking already present there. So I complete my emulsification, and while I'm completing my emulsification, I'm trying to release those hooks a little bit less so that I want only the central part to work with. See, I made it smaller and I'm putting the lens there, and there the lens goes in. And I can see the position. I can just move it with my tubular hook and see where the lens position is okay or not along the way. And as I said, that you can also rotate it anti-clockwise also. And at the end of the surgery, I just get it done. And while removing the hook, what I do is put visco. I remove the visco from behind the lens and then put the visco while removing the hooks. Now, this is one more case, a small pupil where we decided to put a Maligin ring, and the toric lens had to go there. So this is someone was toric is a case of IFIS. I knew that patient was on anti-prostate drugs. So here I get a Rexis around 5 millimeter and end up with procedure. I put this lens. This was a multifocal toric, as you can see. The lens goes in, and there I position it, and I remove the viscoelastic from behind the lens because I don't want to reverse. I see the position there. It is, the position is okay. I tap it, and then once this is done, put viscoelastic over the lens now and remove that Maligin ring, and I know it can be removed easily. As you can see, I just tuck it and bring it out, and then do the bimanual IA and do a little bit of tapping of the pupillary margin so that the pupil comes down. So I don't want any glare, post-operative glare or halos in these patients. Now, this is another patient where on the table, I didn't notice this before. This patient was needing T6 as far as I remember. So, and as I start the surgery, somewhere there, I can see the bag is not stable there. It's coming out. So I put a CTR there. So if I had any eye trace and all, I could have actually seen the lenticular astigmatism that was there. But luckily for me, the tilt was very little. So at the end of the surgery, once you put the CTR and stabilized it, probably some of the toricity that we saw was the patient actually needed around 0.75 cylinder. He was 2.25, needed 0.75 cylinder post-op. But then that was probably of the lenticular astigmatism that was at that time. I didn't have any way of knowing whether it was lenticular or not, which was 10 years back. So the lens was put, as you can see, CTR, you can put it if there is a tilt there, but otherwise also people are putting CTR for high myopes, as said, or toric multifocal. Now this is a case where I taken for toric and it ended up TCL. Let's see that as I'm going ahead with the surgery, somewhere there, as I'm trying to take the last pieces and some of the epinucleus. I think end of the surgery, I realized as I was doing bimanual IA, there is the tear there. Luckily for me, the tear was just superiorly, I mean, where I was sitting, that's on the other side, and I was sitting anyway temporarily. So there it is. You can see, I could see the visco going in there. So that means there was no viscous vitreous there. So all I had to do was high molecular viscoelastic. In this case, it was visco. I have no financial interest, but definitely it has a very good way of plugging that tear, and the lens goes in there gradually. Now, the axis of this toric lenses or the IQ lenses is very slow to open up. You can just get in, tap it in the axis that is there. I know there was this, the viscoelastic is there below. So I just, and then gradually, use your bimanual to remove the whatever little bit of cortex was there and tap it and take out the viscoelastic as much as possible. Patient was on post-op IOP reducing agents, but the patient did well and there was no rotation then over a period of follow-up that we had. Now this was a case, the last case that I was showing. This is a case of 8-year-old child came with sort of PPC with a high cylinder almost. And patient needed almost T8 as I remember. So this child we did there. So we thought we went ahead as we would do any PPC, but later on because I found that it was probably a posterior lenticulus that was there. Once we do a not hydrodissection, the visco dissection we are doing, just visco dissection clearing, and just by bimanual IA we could remove the soft the cortex that was there, and there you can see the stalk of the posterior polar opacity that came out, and then we realized that this was actually a posterior lenticulus, and there was a opacity there. So we went ahead and did a posterior capsulorhexis. As you can see, you just do a posterior capsulorhexis in that area. There's a fibrous plate, and then once you removed it, we put in the lens there, and the lens settled in quite well, easily there, and tag it on, rotate it, and put it at the axis, the marked axis that was there. The child, this was again done almost 6 years back, and the gentleman could see, see the lens is again tucked in, there it is, and the child is still under follow-up now. It's become a teenager now, and there you have it. So these are some of the challenging situations in toric that I had over the years. Thank you. Thank you for having me here, Pati. Thank you.
Thank you, sir. Sir, that was very enlightening, and it does give us the hope that even if we face with some challenge, we can definitely one day go ahead with it. But I'd like to just ask you one thing. What if the rhexis size is too big, or if there is a rhexis extension, then how do you proceed in such cases?
Rhexis extension, I would not put a toric. That's for sure. I mean, I know the torics won't, I mean, they don't rotate definitely. But, irregular, I mean, the size of the rhexis is small, up to 3.54 millimeter. 4 millimeter is easily you can put the rhexis. But if it is too big, again, you might lose the spherical power. The lens might move forward, come out of the bag, and so those problems are there. But ideally, as you said, you need to get a very ideal rhexis in those. But if there is a rhexis extension beyond it, I would definitely, I mean, if it is too much to T79, maybe I'll go ahead with it. But then for early astigmatism,
so, will the direction of placement or the direction of alignment also matter? Like if the haptics are in opposite direction of the extension?
Yeah, in that case, probably if it is there. But most of the time, if the rhexis is a little bit extension, I think almost all of us will do it. And if it is away from the extension, that's fine. But if it is too much, definitely I would abandon it.
Okay, thank you, sir. And I'm sure for all these, you never have any rhexis extensions or big rhexis. You're absolutely spot on with femto or without femto, though most of the cases you're doing is on femto now. So definitely